Hello, welcome to our presentation entitled Improving the Quality of Trauma Meetings by Implementation of a Modern Trauma Management Platform. I'm Benjamin, one of the core surgical trainees at the University of South Manchester Hospital Trust, taking you through our presentation today. So to begin with, we'll start with a short introduction and background about our hospital. So trauma meetings constitute the majority of clinical decision makings for new referrals and also act as a crucial tool to coordinate the trauma list. Our ability to make good clinical decisions within the trauma meeting with the support of other senior colleagues and specialised trauma nurses enables us to provide safe and good quality care for our patients. Alongside this, there are financial benefits of running a well-coordinated trauma list with estimated savings of up to £7 million a year from productive theatres. Wythenshawe Hospital is a large major acute teaching hospital in South Manchester with around 12 specialist orthopaedic consultants. We receive around 70 to 90 referrals per week, which are all entered into our trauma system and discussed in the morning trauma meeting. Our previous system was called Tiger. This was a self-designed computer application produced by a member of the trust around 9 to 10 years previously. It was a simplistic system that divided referrals into two main sections, patients for the trauma list and then new patients to be discussed or new referrals to be discussed. So this is the interface used by Tiger for inputting a new referral. It had mandatory fields including patient demographics, ward location, and the consultant responsible for the patient's care. There's then a free text entry box for the presenting complaint and history, as well as an entry field for the up-to-date plan for the patient. So whilst this system had worked for numerous years, it did have some significant drawbacks. Firstly, the free text entry meant that particular aspects of the referral history may be missed, for example, social history, mobility, smoking, and allergy status, which overall meant the quality of the referrals wasn't ensured. There was also the ability to override the previous entry, which is evidently not good for medico-legal purposes. One considerable problem was the organisation of the trauma list with patients placed in chronological order on the trauma list section. It was impossible to establish the order of patients on the list and which patients were to be prioritised. Another issue was with documentation of the plan and outcome from the trauma meeting, usually requiring a post hoc entry to each referral by the trauma nurses. Finally, juniors were unable to make custom inpatient lists from the trauma system, which would have been an added benefit. So the management department agreed for financing and implementation of a new system named eTrauma. This is a recently developed cloud-based patient management platform. The system's proposed advantages were as follows: prompted data entry fields with the aim of improving data inputting, an audit trail and coding of data. Obviously, this is good for medico-legal documentation and also for data capture for research, audit and quality improvement purposes, and also the coordination of the trauma list. So this is one of the key benefits of the system we could see. It allowed interactive management of the trauma list with the duration of the operation, what operation was to be performed, and the outcome of the operative session, and this allowed it to be tracked in real time. So this is the trauma screen for inputting referrals with numerous prompted data entry fields. So obviously when you start inputting on the fields, the data codes come up, allowing you to code as you're inputting the referral. So in terms of the aims of the study, the primary SMART aim was to improve the quality of patient handover and structure of the trauma meeting. We developed 21 key data points based on the Royal College of Surgeons guidelines for a good patient handover and incorporated 4 additional points that are needed for a good orthopaedic referral. These data points could then be audited against to indicate the quality of data inputting on the trauma system. And our aim was to show an improvement in at least 50% of the data points at 1 and 6 months re-audit periods. So this slide shows our 21 key data points, which were divided into 2 key sections: patient demographics and also referral details. So our secondary SMART aim was to provide a qualitative measure of trauma meeting handover. To do this, we developed an 8-part questionnaire which focused on those 4 key areas outlined. Our aim was to show improvement in at least 75% of questionnaire responses by the end of the 6-month re-audit period. So this slide demonstrates our 8-part questionnaire that I'm happy to go back to at the end or send out. So prior to introducing the new trauma system, 150 referrals using the Tiger system were audited and compared to our key data points. To get a baseline opinion of how the trauma system and morning meeting was functioning, we distributed 25 questionnaires to members of the orthopaedic team, ranging from junior doctors, consultants, and trauma nurses. And following this, we successfully introduced the trauma system on the 30th of September. At each re-audit point, we audited 120 eTrauma referrals and distributed a further 25 questionnaires. So looking at the quality of data entry with the new system, significant improvements were seen in 2 key data points regarding the patient's demographic details. Firstly was the documentation of the patient's NHS number, and secondly was a significant improvement in the bed allocation, hopefully allowing the post-take ward round to run more smoothly. In terms of the key referral details, vast improvements were seen. All of the key data points outlined in the blue squares showed improvement. There's improved documentation of data points, including mechanism of injury and past medical history, as well as investigation results, hopefully meaning an increased quality of referrals and giving clinicians a greater range of information to make their clinical management plan. With regards to our questionnaire responses, they initially felt that it was less structured using the new system. This improved to near baseline levels by the 6-month period, and this is probably due to familiarity with the system. With then improvements in communication and documentation of operations to be performed, and also communication and documentation of any changes to the management plans showed a significant improvement with the eTrauma system. So why are trauma management systems important? They're firstly integral to the functioning of the trauma meeting, so high quality referrals with all data included allows clinicians to construct the best possible management plan. If it's easy to navigate, it allows a smooth flow to the trauma meeting. In terms of the coordination of the trauma list, it's imperative that all theatre staff are clear on the trauma list order, and that allows them to prioritise patients and plan their lists. In terms of medico-legal protection, it should allow an audit trail and documentation of morning meetings, which ensures safe management of patients. In terms of limitations, we couldn't account for an audit effect of people knowing that an audit was ongoing. I think that we could have distributed questionnaires to all members of the trauma team rather than just 25 questionnaires. And also we could have assessed the speed and functionality of the new system. And that's potentially what we're going to look at in future prospective studies. So to conclude, the introduction of a new cloud-based management platform has had a positive impact within our trust. Significant improvements were seen in the quality of electronic trauma referrals, an increased clarity of the trauma list, better documentation of operations to be performed, and an improved documentation of management plans for new referrals. So thank you for listening, and I look forward to answering your questions via the online system or via email. I've put my email there, and there are my references. Thank you for listening.